All right, so since time is of the essence, I'm going to go ahead and get started here. So what we have left to discuss for Chapter 11 is the provider side interventions that managed care implements. So that includes interventions for physicians as well as hospitals and related organizations. Good afternoon.
Hello.
Um, all right, we'll go ahead and jump right in then. So today, we are looking at the remainder of the interventions that are utilized by managed care organizations that pertain to the provider side. So that includes interventions for physicians as well as hospitals and similar type of organizations. And then we'll look at which interventions seem to work best. And then we'll talk about some long run related issues to those interventions. So traditional health insurance has tried to control costs through sort of the consumer side of things, providing consumers with incentives to reduce costs. Um, but modern managed care, in addition to using these strategies on the consumer side, is also beginning to employ some provider side incentives. So that's what we're going to look at. So the first thing with which we've seen a little bit of before are different types of payment schemes for doctors. All right. And this is actually one of the most widely studied methods of trying to change provider behavior is their form of payment. And we actually discussed a lot of this already in chapter 7. And the main distinction is between salary, a flat salary, versus fee for service. Um, And so the idea of a fixed salary actually came about in sort of the original or classic health management organization, where all of the medical treatment for enrolled patients came from a closed panel of doctors, all of which were on a fixed salary. So that's kind of the basis uh, for the idea was these original HMOs. And the literature is pretty abundant on this issue. It can provide us with a lot of good information on the effects of the compensation scheme. But we have to keep in mind that the data and the evidence isn't necessarily conclusive or definitive, primarily because we're kind of violating the ceteris paribus assumption. We're not only changing the payment scheme from fee for service to salary, but we're also changing many other things. So we have to take the results with a grain of salt, right? Right. So, for example, not only is it changing payment schemes, but it's also doing things like utilizing preventive care, right? So that could potentially be what is causing what we observe. So we do have to be careful. But we can turn to this sort of the differences between HMOs and fee for services to look at to gather some insight on this issue of payment scheme. All right, so like I said, this idea of paying doctors on a salary rather than fee for service originated with the classic HMO, and in fact, um, the originator was the Kaiser Permanente Corp, which I'm sure you may have heard of Kaiser Permanente. They're still around, but they did this in the 1940s on the West Coast, so in Portland, Honolulu, and Los Angeles. It was originally designed as a way for them to provide healthcare benefits to their employees. So they weren't aiming to create some sort of innovative new insurance for the broader market. It was really for their own internal purposes. And so what they were going to do was hire doctors themselves and either build their own hospitals or alternatively contract with other hospitals for their services, and basically have their own like little medical group just for their company, where the doctors were paid on a salary basis. But the key feature here is that with a salary, there is no longer a financial incentive to provide excess care. So in a sense, it eliminates a lot of the possibilities for induced demand, right? Whereas fee for service, the doctor is getting paid for each procedure that they operate or conduct. And so there, with fee for service, there's definitely an opportunity for induced demand because of the financial incentives involved, right? The doctor gets paid more if they perform more procedures. So obviously there's an opportunity for induced demand there. But the fixed salary eliminates that. So a lot of times this type of payment scheme is called capitation payment, because payment is basically based on a per person basis or per head basis. So therefore the per capita type of measurement, right? Capitation. And so if we compare this to fee for service, where providers do better financially when they provide more care, we can see that the incentive setup is definitely different, and the capitation type payment does not really create an opportunity for induced demand. So with fee for service, really the insurance company is at risk in a big way, right? If doctors are paid on a fee for service basis, and therefore are perhaps financially motivated to induce demand, the person or the company paying for that is the insurance company, right? So it's really affecting the insurance company the most, while the patient and the doctor really aren't bearing that excess risk, right? So the two parties that are most pivotal in making the decisions about medical care have no financial incentive to conserve resources. And so this is really the main problem with fee for service, right? And we've been talking about this issue already so far. So this should be relatively familiar. So in this sort of pure capitation model, doctors and hospitals are paid either a flat salary, or they're paid based on some sort of agreement about how many covered lives they care for. So a capitation per head agreement, right? And regardless of how many people it is, they agree to provide all of the necessary care in exchange for the fixed payments, whether it's salary or per person type payment. So this obviously drastically changes the incentives for both doctors and hospitals. And the outcome is pretty severe, right? Compared to fee for service, where they're motivated to provide extra care that may be unnecessary. With this setup, with capitation type payments, they actually make more money by preventing the use of care rather than expanding it. And so, that kind of brings up one issue, and that's that, well, if they're motivated to prevent care, what's going to keep them from under providing, right? Well, there still are legal requirements as well as other market incentives to provide adequate amount of care, but they now have a direct incentive to control costs, which is really um, the main change, right? So how does it work with HMOs? So as it turns out, most doctors are essentially separate legal entities, and they enter a contractual agreement to provide care for the HMO's enrolled patients, typically exclusively at the HMO's hospital, whether it's their own hospital or a hospital they have a contract with. And then patients pay a fixed premium for the year of coverage. Um, and then the physician group gets to share in any extra money that's left over at the end of the year. So they get a bonus if they cut costs, right? So not only are they incentivized to reduce costs because they're paid a flat salary, but they also have the potential to earn bonuses if costs come in under target for the year, right? So now there's really strong incentives to avoid using unnecessary resources. And on top of that, the HMO can also avoid some coordination problems that large group insurance typically face because they can easily fire doctors that don't cooperate. And as we learned previously, in other arrangements, it can be difficult to fire doctors for several reasons, right? But that barrier or that limitation is sort of relaxed for HMOs. They have an easier time firing doctors that don't perform well or don't cooperate. Okay, so the main thing we've been talking about here is entirely a provider side or a supply side incentive. It has really nothing to do with consumers, and the majority of the cost savings actually come from reduced hospitalization. Hospitalization is a really expensive part of care, and that's where most of the cost savings are come from is reducing hospitalizations. And that's pretty well documented in the empirical evidence. So many studies have shown how HMOs can reduce the propensity to use hospital care compared to fee-for-service arrangements. Um, and on top of that, the sort of non-experimental studies were confirmed by the RAND health insurance study, because we didn't talk about it in detail when we talked about it, the study, but we mentioned it and said, oh yeah, we'll talk about this later in chapter 10 or 11. But there was a small sort of sub study in the RAND health insurance study where they took some patients and enrolled them into an HMO in Seattle, Washington. And the results of that subgroup support the non-experimental evidence. So in the RAND health insurance study, these HMO patients were compared to the other people in the study that had full coverage. And also, they were also compared with a set of patients that were previously enrolled within the HMO sort of independently of the study. So this first comparison between the health insurance study HMO and the other enrollees in the full coverage insurance plan, where there was basically a fee-for-service payment scheme, that first comparison allows us to test the effects of the HMO incentive system. The second comparison between the health insurance study HMO and the previously enrolled patients in the previously enrolled HMO allows us to get an idea of whether there's sort of unfavorable or favorable sets of patients within the HMO. Because the HMO that they're comparing it to was basically not a randomized control trial. It was just people that self-selected the HMO. And as we've seen before, when there's self-selection going on, it's possible that sick people try to pretend to be healthy people and get that good insurance at a low rate, right? So that's the issue here is are the results that we're seeing, are the cost savings that we're seeing because of self-selection rather than these incentive systems, right? That's really what the second comparison is able to tell us, right? Are the HMO results being driven by a favorable set of patients, or are the results being driven by the fact that there are these supply side incentive schemes and other supply side incentives, right? So that's the main question. And there's two important results from these comparisons. The first is that the HMO, the controlled one, used considerably fewer resources compared to the full insurance, full coverage fee-for-service plan. And keep in mind, these are all comparisons within Seattle, right? The second result is that the health outcomes of people enrolled in the experimental HMO, it's a typo, just HMO, not HMNO. The second result is looking at the health outcomes, right, between the HMO and the people in the fee-for-service plan. And it was found that the HMO enrollees fared at least as well as those on the full coverage plan. And so what's really important about that is that while the HMO was able to reduce the use of resources, there wasn't any reduction in health outcomes. So they're saving money, and people are just as well off with the HMO as with the fee-for-service plan, which is great. They're saving money, and people are just as well off, right? So table 11.4 kind of gives us a summary of some of these findings, right? So let's see here. So here's the HMO experimental group, the HMO control. So this was the group of people that self-selected the HMO. They weren't part of the study. And then, of course, compared with the full coverage group within the RAND study. And we can see that, sure enough, the HMOs use fewer resources. And most of the reduction in cost is coming from hospitalization. There's not much of a difference in ambulatory care, right, which is stuff other than hospitals. So again, most of the cost reduction is coming from a reduction in hospitalization, and you can look and see that the total cost is in fact lower and is lowest for the experimental group. So definitely some cost savings, and it seems like most of it's coming from the fact that there's fewer hospitalizations more than anything else. All right, so we have these two different payment schemes, but we do have to be aware that there may be some problems with the salary-based system that we haven't thought about yet. Now, of course, we've seen the issue with fee-for-service payment plans or payment schemes. There's this incentive for doctors to provide too much medical care, right? So we've seen that before. But there's also a potential problem with these flat salary-based types compensations. With those compensation schemes, there's an incentive to shirk, and there's also potentially an incentive to withhold treatment if doctors are able to share in the cost savings, right? So that could potentially be a problem. And so because of these potential issues, some people have begun to think about some sort of blend of these two compensations in order to provide a better possible outcome than either one individually. Okay, so a blend of fee for service with some type of flat salary-based compensation. Okay, so Ma and McGuire modeled this theoretically. Okay, so they built a theoretical model based on this blend of payment schemes. And they found that the optimal blend will depend on the strength of the adverse effects created by each scheme. Okay, so if the demand inducements are a bigger problem coming from the fee-for-service type payment, then the salary component will be a larger part of their compensation, and the fee-for-service component will be smaller. But if shirking and withholding care is more important, then the fee-for-service component of compensation will get bigger and the salary component will get smaller. So pretty straightforward. That seems to be, at least to me, pretty intuitive, right? And something else that kind of has an impact on the results is how hard doctors will work under the different compensation arrangements. Um, and so there's some evidence on this from Gaynor and Gertler. They found that as physicians are paid more and more by salary, their work effort shrinks, which is an intuitive result as well, right? If they're just paid a flat rate, then there's an incentive to slack off, essentially, right? Their payment doesn't matter on their effort, so they might as well just take an extra long coffee break, chat with the nurses and the receptionists a little longer in the morning, those sorts of things, right? Um, and the effects are worse in bigger firms because it's harder to monitor each individual physician. And this is pretty standard stuff from labor economics. Actually, this is standard labor economics. If you've taken that class. In small groups, salary paid physicians worked about 2/3 as much as doctors in the fee for service model. And in the largest groups, the work effort dropped to about 40%. So 60% decrease, right? So just as we would expect, it's a problem. Doctors that are paid salaries shirk, and it's worse when the doctors are part of a larger group. Right? That's exactly the effects that are captured by their theoretical model. So this is an area where there's still work that needs to be done. It's a potential place for improvements, right? But it's not exactly clear what the appropriate blend of these two is, right? There's still some issues that need to be worked out. All right. Another provider or supply side intervention are known as holdbacks. Okay, so this is basically when the insurance plan holds back a part of the physician's payment until the end of the year to see if costs are within their targets. And if the plan comes in at or below the target costs, then that holdback is dispersed back to the doctors. But if the costs are above what's targeted, then that holdback is kept in order to cover the costs. So in a sense, doctors as a group are sort of at risk to cover these excess costs. So they're motivated to reduce costs so that they can hopefully get that holdback back at the end of the year. Right? So doctors are sharing in the losses of the MCO. So they have a direct incentive to control costs. So this is an interesting intervention, right? It helps the MCO deal with potential cost overruns, but there's some doubt on whether this actually enables them to lower costs. And the main issue here is that there's very little incentive for any individual doctor to engage in lower cost treatments from resulting from the holdback. And to think about this, what we're talking about here is really a prisoner's dilemma. Okay, if they do cooperate, they are likely to suffer relative to their peers, right? So suppose that one doctor actually puts in the effort to reduce costs, but nobody else does, right? Well, then that one doctor is not going to get the holdback. And so relative to everybody else, they are worse off. And so really the better choice is do not cooperate, which is of course the standard prediction of the prisoner's dilemma. And so, and then we have a real issue, right? Nobody ever cooperates, and this whole thing just falls apart. So there's some serious doubt as to whether this really can effectively reduce costs, because it's basically a prisoner's dilemma, right? Right, cooperation almost always falls apart in such case. And really, again, it's because each doctor has sort of a shared incentive to reduce costs, but it's a small fraction, right? The reward of doing so is small relative to the cost of effort as well as relative to the potential benefits of getting that holdback back at the end of the year, right? So the doctors don't end up trying to cut costs, and the cooperation falls apart, right? So there's some serious doubt about the effectiveness of this type of scheme. And I think that that's probably evident too in how infrequently it's used. It's not very frequently used. And you can also imagine that doctors might not like this very much, right? You're going to hold a huge chunk of my payment until the end of the year and I might not get it back. Yeah, right. So there's, of course, other issues as well, but the main one is this prisoner's dilemma issue. Now, aside from physician type interventions, there's also potential interventions for hospitals and similar types of organizations, right? Now, hospitals have sort of this distinct characteristic or characteristics that make them eligible, that for a type of payment that's kind of between FFS and capitation, kind of like almost like a blend in a way, like we were talking about for physicians, but essentially what they are paid by is on a per case basis. Okay, so or a per event basis, per hospital event. And this is easy because a hospital event has pretty clearly defined boundaries. It's pretty obvious when a patient becomes hospitalized, right? There's lots of documentation. It's not something that's hazy or fuzzy. It's very clear when these types of events occur. And so insurance plans can pay hospitals for single events in sort of lump sums, right? And this is not the same as fee for service, nor is it the same as capitation. Okay, so it's kind of somewhere in between, I guess. Um, and this type of payment system actually came from the federal government and their desire to control hospital costs under Medicare. So let's look at the details of that. So basically, what happened was the federal government created this what's called a prospective payment system, or PPS for short, that involves nearly 500 diagnostic groups, DRGs. And so this was, again, something created by the federal government, but it has actually been adopted by several private insurance plans as a payment system. And we're going to talk about the details of the DRG system and where the system arose in Chapter 12 when we talk about Medicaid and Medicare. So we'll see that next week. Now, there's also this issue of provider selection, right? Remember that these HMOs or these MCOs typically have in-network doctors and out-of-network doctors. So here we're talking about the selection of those doctors that would be in-network or part of the group. So a huge part of the MCO model is careful selection of providers that are low-cost providers, right? And so, and this cost savings can come from sort of two sources, right? The first is that if there's sort of intrinsic differences between the costs of various providers, then the plan simply seeks to find those that are low cost, right? But there's also this issue of the cost structure of providers. If a particular provider has been charging a substantial markup, right, pricing high above their actual costs, then it's easier to negotiate down their costs. So there's also this issue of negotiation, right? So not only is the insurance plan selecting low cost providers, they're also looking for doctors with which they can potentially negotiate down the price, right? And there's, really perhaps the most important evidence on the efficacy of these plans, and that's their rapid growth in the market. We've seen them proliferate, right? We saw this data last time. PPOs are now a substantial portion of the market, and it appears that that can really only be true because they are effective, right? So that's the evidence on that. Now, are some studies that provide us with direct evidence, and one of those looked at primary care physicians in Rochester, and they showed that there were large and systematic differences in the total cost of treating patients. And they were careful to control for things like underlying illness, and so they were able to conclude that the doctors in the study had identifiable and reproducible practice styles that allowed grouping into relatively lower and relatively higher cost providers. So just by looking at their styles, the study was able to sort of group into low cost providers and high cost providers. Um, but the interesting thing is that neither of the competing plans, neither of the competing insurance plans, would commit to limiting their choice of provider to the panel of physicians in the lower cost group, which is interesting, right? Here you have the whole point of these MCOs is to lower costs. So why would they not commit to lower cost providers? And there's potentially a range of explanations for this. It could be that they don't want to limit themselves to a particular group, because having a broader class of doctors could potentially bring in more customers and those sorts of things. But this is kind of an interesting result, right? We can clearly delineate relatively easily low cost providers from high cost providers, but at the end of the day, the MCO wasn't willing to commit to only selecting the low cost providers. They wouldn't constrain themselves in that way, which is kind of ironic actually, because that's the whole point of MCOs, is they're putting constraints on doctors and consumers to try to reduce costs, but they won't do it to themselves, which is kind of ironic. Um, Now, this whole discussion of cost savings, particularly with low cost versus high cost providers, sort of brings up the question of quality, right? You know, it may be this group of doctors is lower cost, but what about their quality? Is it really suffering because of their low cost, or is the quality of their care comparable to the high cost group? In which case there's not much need for concern, right? But there was one study on this issue, and they used New York State's report on the quality of care of surgeons as well as hospitals for cabbages, right? Coronary bypass artery grafts. And this study was Mukamel and Mushlin, and they basically looked at the probability that an MCO would contract with a cardiac surgeon. And what they found was that MCOs preferred doctors, cardiac surgeons that had better RAMR, which is basically a measure of quality. It's risk adjusted mortality rate. Okay. So something similar to what we've seen before with QALYs and dailies, I think, right? But risk adjusted mortality rates. And they also found that the MCOs tended to avoid low volume providers, maybe because the volume is sort of an indication of quality, perhaps. But this study, at the very least, suggested that the quality of care can also affect the choice of provider by the insurance plan, as well as the cost of treatment. So there is some sort of interaction going on. Not only are they searching for low cost providers, but the insurance plan also cares about quality as well, right? When they're selecting providers. Another sort of study, as well as a natural experiment related to these issues, came from California, when a large insurance carrier there made a pretty substantial change. So Blue Cross of California was kind of the first among its peers to abandon rewards that were linked to cost control in its HMO and MCO plans. So it totally abandoned these sorts of cost savings payment schemes, and that would include salary-based payment, as well as anything like that was potentially like holdbacks or anything like that. Um, and in its new structure, in its new payment scheme, it created a set of bonus payments that was directly tied to patient satisfaction. So this is really interesting. So the incentives, the payments were no longer incentivizing cost controls; they were purely incentivizing patient satisfaction. And basically, what the new system did was to offer incentive payments of up to 10% bonuses for the highest satisfaction scores, um, coming from random surveys of patients enrolled in the plan. Um, so that was the mechanism how they implemented the bonuses was with these surveys. So that was a pretty interesting change. I don't think at the time of the textbook being published, there really wasn't too much evidence on the effects of that. But I'm sure at this point in time, there have been substantial number of studies that looked at the effects of that change. So it'd be interesting to see the effectiveness of that and whether it was still able to control costs at all. I would suspect that costs wouldn't be as controlled because, one way to provide better satisfaction to the patient is by providing them with more things that cost money. so so I would be surprised if the cost savings were still intact with that change. But in addition to selecting providers, MCOs are also choosing hospitals, right? So there is some evidence on this. Um, so Zwanzinger, Melnick, and Bamazai studied the consequences of California's introduction of this sort of what's called a selective contracting. Um, and this was both through the state's Medicaid program, which they call Medi-Cal in California, as well as by the introduction of legislation that allowed selective contracting in private insurance markets. And what they found was there was a strong negative relationship between the degree of competition, which they measured as market concentration, and the rate of cost growth after selective contracting emerged. So it appears that this selective contracting has sort of dampened the increases in costs where there's a strong degree of competition, right? So when there's a lot of competition, the increase in costs is dampened. So more competitive markets have less growth in costs. So that's good, right? This implementation of selective contracting has helped control costs. There is one other sort of selection that's occurring, and that's when MCOs limit the choices of consumers regarding prescription drugs. So one other way to sort of constrain consumers and or doctors. So a lot of MCOs now have what's called a formulary of drugs. So basically a list of drugs that are sort of acceptable to be used. And the drugs that have the highest amount of coverage are typically generic, right? They're lower cost. And then they also include one or two more expensive tiers of drugs, but they put those costs on patients. So it's like, all right, if you want the name brand drug and you don't want the generic, then you're going to have to pay for it, right? And in that way, it doesn't affect the insurance company's costs. The extra cost is entirely borne by the patient. And we could look at this in more detail in chapter 15. We're not going to get to that chapter, unfortunately, this semester. But if you're interested in looking at that, that's chapter 15. Goes into more detail on that issue. I think that's the chapter on externalities. I can't remember exactly. I guess I could look. One second. Okay, that's the chapter on market regulation. Anyway, all right, let's keep trucking along. We're making pretty good time here. Hopefully we can finish this. And of course, stop me if you have any questions, because I am kind of going a little fast here. But another way that these managed care organizations might attempt to control costs is with fee schedules and price schedules. Right. So one of the essential features of PPOs, right, a particular type of managed care organization, is to bargain about price with providers, right? Try to negotiate down their price. And it seems like these types of attempts would be most compelling when there are substantial markups being charged by physicians, right? The bigger the markup is, the more potential there is to be able to negotiate down the price. And the way that a PPO works is that it enrolls a group of people, promising them low premiums. It negotiates prices with providers, promising to bring them a high volume of patients in exchange for a more favorable price. So to the extent that PPOs are successful in gathering more patients, it's able to enhance its ability to convince more providers to join the organization. And that also gives them more leverage in bargaining for a better price. So all of these things are kind of codependent, right? Promising low premiums to patients to get a lot of them on board, and then going to doctors and saying, hey, look at all the patients we have. If you give us a better price, we'll give you access to all these patients, right? And also, as the PPO gets more providers, it also becomes more attractive to consumers. So all of these things are kind of feeding back on each other, supporting one another. And so what's going to determine whether the PPO is ultimately successful is its ability to gather both patients and providers. And really, the only limiting factor is the proportion of patients that are sort of unwilling to accept the limitations that come with managed care, right? And pay for some other type of insurance that might be higher cost, although gives them more generous benefits, right? So that's really the limiting factor is how many people are willing to be part of a managed care plan, since it does impose limitations. Now, if setting prices didn't affect providers' behavior, then the only benefit would be to lower the overall premium. But we have to think about what the true effects of negotiating price might be. Um, there might be other effects other than just lowering costs and premiums, right? Negotiating price might also affect the quality. And so negotiations can alter the mix of services provided by altering the relative prices of different procedures, right? So again, the insurance company is setting prices, right? It's setting a price schedule or a fee schedule for different types of procedures. And so it's essentially altering the relative prices of these different procedures. And so it can actually have an impact on the mix of the different procedures that the physician might be willing to provide, in addition to the quality, right? The quality issue. Now, quality, we've thought about quality before, right? When there's higher levels of quality, the demand curve is higher. And when there's lower levels of quality, the demand curve is lower. And we can think about that in the context of lots of different things, right? So there's really nothing different going on in healthcare. And we saw in chapter 9 the sorts of things that not-for-profit hospitals use to select output, price, and quality when they have consumers with sort of standard insurance plans. But MCOs change that, right? They change those arrangements when they bargain on price. Um, and it's basically because, they bargain on price and they say, okay, hospital, these are the prices we're willing to accept, but they don't say anything about the types of quality or quantity that the hospital has to provide, right? They're just setting the prices and then they leave it to the hospital to alter the quality and quantity given those constraints provided by the price bargaining. So these are things we have to think about. What might the hospital do in terms of its quality or quantity given the set prices, right? And the same types of things would happen with a physician firm. Really no difference there. If the insurance plan comes in and negotiates prices with the physician firm, then it's left up to the physician firm to choose levels of quality and quantity. It's also possible that other characteristics of quality might change in response to the lower negotiated prices. And this could include things that might be in the longer run, like the quality and extensiveness of medical equipment that they use, the inventory of supplies, and perhaps even things like the quality of furniture in the waiting room, or even the number of magazines and the type of magazines in the waiting room, right? And so MCOs altering the arrangement by bargaining on price are basically gonna leave these sorts of quantity and quality issues up to the discretion of the hospital or the physician firm. There is so far all of the interventions we've talked about are sort of um, pre-treatment, right? So they all take place sort of before treatment, except for maybe the holdbacks. You could kind of argue that takes place after treatment. But there is an entire other class of interventions that take place at the specific time that decisions are made regarding medical treatment, right? So far, what we've seen are sort of what are called interventions that take place in the large. I'm not really sure what your book means by that, but I guess it means sort of in the large scope of things. But there are also potential interventions sort of that take place in the small. And there's two in particular. One of them is called prior authorization, and the other one's called denial of payment. Okay, so prior authorization is pretty straightforward. It just means that before the doctor can perform a particular procedure, they essentially have to get the permission of the insurance company. They have to get authorization. And in most cases, it's approved. There's not many cases where the insurance company denies it, but there are instances where they approve it with limitations, right? So there's limitations attached. And so even though permission is often granted, these limitations can often alter the behavior of the physician, and it's particularly typically with regard to the discharge of the patient, right? How long should they stay in the hospital? And so in these cases, the sort of hassle or cost of getting the authorization offsets the gains from extending the stay of the patient, right? So this typically leads to a reduced length of stay for the patient. So that's prior authorization. The other one, denial of payment, is a potentially very powerful form of cost control, although it is somewhat controversial, right? It's basically saying, um, okay, we're not going to place any limitations on what you do, but there may be instances where we choose not to pay you back, right? And so this one in particular definitely takes place after treatment has been rendered. And so basically, in these cases, either the doctor has to eat the cost of treatment or the patient or some mix of the two, right? Since they're not being reimbursed by the insurance company. And so really the incentive that's created here is that it causes physicians to be very careful about which treatments they go into, which treatment protocols they decide to use. And then they also are thinking about, well, which types of treatments am I most likely to be denied payment? And so it kind of makes them more cautious um, about their treatments, the treatments that they provide, right? And so that can definitely reduce costs, but it is a pretty controversial form of cost control. And there's also this issue of sort of a fuzziness or blurriness between the boundaries of these two types of interventions. Um, in many cases, the MCO might refuse to authorize treatment, and a lot of times this might be described as a denial of payment, right? Oh, they're not authorizing this, that's a denial of payment. Um, and sometimes even the process of deciding whether to deny authorization or not can lead to a lot of major disputes. And in fact, there was a landmark case where patients sued an MCO over the denial of treatment. The lawsuit was centered on the amount of time that took place between the request for treatment and the actual decision. Um, so these are somewhat controversial means of trying to control costs, and the boundaries between them can be somewhat blurry. So those are the interventions. There's a whole array of them. Some are less effective than others, and so the real question then is which of these work best, right? So Cutler, McClellan, and Newhouse um, looked into this, and they came to a provocative and potentially important conclusion. Now, they were using data from a set of Massachusetts health insurers that used both staff model HMO, PPO, as well as indemnity plans. So, a variety of different types of plans. And what they looked at were the rates of use of various types of treatment for acute myocardial infarction and ischemic heart disease, so heart issues. Um, and they also looked at the prices paid for these services. And what they found was surprising to some. What they found was that the AMI patients received about the same types of treatment in all of the different health plans studied. So the HMOs, the PPOs, and the indemnity plans. And so these treatments included things like similar hospitalization rates, similar average lengths of stay, similar cardiac catheterization, as well as bypass surgery and angioplasty. So similar outcomes on all types of plans. Um, and what they also found was that the cost savings from the managed care approach came almost entirely from the price per unit of service that was negotiated. So the price negotiation is really what was driving the cost savings. Okay, so the specific figures that they found was that the average payment from the more traditional indemnity plans was about almost $40,000. For the PPO plans, it was just over $25,000, which was about 70% of the indemnity plan. And for the more aggressively managed HMO plan, the average was almost $24,000. So a little bit of additional savings compared to the PPO. And this occurred despite the HMO's actual use of invasive procedures slightly more often than the indemnity plan. So this is interesting, right? This is the surprising part. The HMO used invasive procedures slightly more than the indemnity plans, but saved a substantial amount of money, almost 30%, right? Um, so that's a pretty surprising finding. They also found similar patterns for treatment of patients with the IHD. What did that stand for? Can't recall. Ischemic heart disease. There we go. So they found similar patterns of expenditure there. where the average reimbursement was $7,000 under traditional plans, $5,000 for the PPO, and $4,000 for the HMO. So very similar patterns. And the patterns and proportions are quite similar to the AMI results. So there's a couple important things to note from this study, or I guess just overall, in fact, not just from this study, but overall. The first thing to note is that managed care has actually squeezed out a considerable level of fat, right? Cutting the fat in the prices for healthcare. And a lot of that comes from the price negotiation. But something else to note is that about 75% of the possible gains from managed care comes from simply negotiating price. The remaining 25% of gains came from the actual management. So the name itself is maybe a bit misleading, right? Maybe it should be negotiated price care or something like that rather than HMO. But given these conclusions, we do have to be careful because the study really only looked at two specific disease conditions that were related to the heart. So it's hard for us to extrapolate these findings to other types of procedures and other types of care. But it does shed some light on how managed care plans manage to reduce costs. Okay, now moving on to sort of the longer run issues related to these types of cost savings plans. So all of these interventions could potentially have longer term effects. So in particular, hospitals are going to have a lower demand, right? Because a lot of the cost savings we've seen come from lower rates of hospitalization, which means the demand for hospitals is declining. And so one thing that we might see in the long run is that hospitals might convert to sort of long-term care facilities, like retirement homes and those sorts of things, or they might just straight up close, right? So those would be sort of the longer-term effects, potentially. Additionally, what we should see in the long run is that insurance organizations are going to experience their own growing pains as they continue to experiment with different cost-saving strategies and as they discover which of those are the most effective. And ultimately, all of these things will have an impact on things like physician income, the geographic distribution of physicians, their mobility, switching between geographic regions, as well as their retirement decisions. All right, so let's think about those in particular. And so we've been seeing that MCOs have placed quite a bit of stress on physician services market. They've really kind of changed the landscape for physicians, particularly when it comes to payment schemes, right? So this is in general due part to the incentives that are provided, but also the specific choices of MCOs in emphasizing primary care, right? Particularly with things like the gatekeeper model and requiring patients to see a physician, a primary care physician before seeing a specialist. And so one thing that this has done is kind of flipped the sort of financial status of primary providers versus specialty providers. It used to be the case that specialists undoubtedly made more money. But under this landscape of NCO, where they're requiring primary care physicians before people can see a specialist, now it's the case where, oh, well, primary care physicians might actually be more lucrative, right? And so that's something that might impact the decisions of physicians, right? We might see less physicians deciding to become specialists and more of them becoming primary care providers if MCOs become more and more prevalent. Okay, so not only is it affecting specialty choice, but it could also affect the retirement decisions as well. And in fact, we can see some of this happening currently. Now, one way to look at these issues is to compare the staffing patterns of more traditional group practice HMOs with the overall US healthcare system. And despite the fact that these types of models are not necessarily the favorite of consumers, it does provide us with sort of a benchmark of personnel utilization that is worth understanding. So that's what we're going to look at in table 11.5 here, is the staffing patterns. And this data comes from 1992. All right, so what we see here, we've got total US supply of physicians per 100,000 population. So overall, 180 physicians per 100,000 population. Yeah, and then we can break that down into different subspecialties. So we've got primary care, almost 66 doctors per 100,000, and so on. So we've got about 18 medical subspecialists, about 44 surgical subspecialists, about 22 hospital-based physicians, and about 20 other physicians. And then what we see here are different types of HMOs. So we've got the 7 Kaiser plans, the Kaiser Portland plan, and the GHC Seattle plan. And all of these figures are relative to overall US supply. So for example, within the 7 Kaiser plans, this 0.62 represents, basically is telling us that 62% of all physicians are part of this Kaiser plan, okay? And then we can see other proportions. The Kaiser Portland plan, 76%, GHC Seattle, 68%. So what we're seeing is that these plans are capturing a substantial portion of these physicians, except for the hospital-based physicians with regard to the 7 Kaiser plans. But in any case, what we're seeing is that a large number of physicians, a substantial proportion rather, are part of these sorts of HMO plans, and not a smaller proportion is not part of those plans. Okay, so what we're getting from this data is basically the approximate equilibrium demand for physicians in a strongly managed care environment. And basically what we're seeing is that there's an important decline in the employment of specialists of all types. That's really the main takeaway, is that there's sort of a shifting in landscape from specialists to primary care providers. And to kind of get an even clearer picture, we can sort of extrapolate these data to the US as a whole, because this was kind of focusing in on one particular area where there's a lot of managed care going on. But if we extrapolate this to the entire US, we can basically find that those with multiple $100,000 earnings would eventually find their incomes declining, and perhaps even reaching a place where they would want to essentially they'd rather be unemployed, which is kind of crazy. But we do have to be, again, careful, take this extrapolation with a grain of salt, because the staffing mixes reported in the table are not only 3 years old, but also from this particular region. But the general conclusion about physician supply probably still stands, even though the data is relatively old and from a particular region. Okay, so fewer doctors are choosing to be specialists, more are choosing to be primary care physicians. Something else that happened was that Medicare's payment schemes that were instituted in 1992 are going to enhance these trends because they lower the earnings of specialists, emphasizing procedures such as surgery, et cetera, and they increase the earnings of doctors that emphasize cognitive skills, such as doctors that are internists or that practice family medicine. And we're going to look at this in the next chapter when we look at the Medicare payment reform known as resource-based relative value system. But here we can study separately the effect of managed care growth on physician earnings in the time being. So Simon, Dranove, and White looked at this issue, and what they concluded was that managed care penetration enhances primary care physicians' earnings significantly. So again, primary care physicians are now making more relative to specialists than they did previously. They also found that it significantly cuts into the earnings of a group of hospital-based specialists. So people like radiologists, anesthesiologists, pathologists. So these are all doctors that basically kind of need a hospital, and their earnings were cut by comparable amounts. And of course, we've seen economic theory that tells us that physicians are going to locate themselves in a way to sort of equalize their earning opportunities across regions. And so the greater penetration of NCO into markets will affect mobility, at least of some physicians, but perhaps not all, right? Because it is altering the incentive schemes, the financial compensation of doctors, and that's at least in part what helps them determine their geographic placement. Now, it is typically found that younger physicians are more likely to move facing these influx of MCOs compared to older doctors, because they have more time to sort of amortize the costs of the move. Older doctors are kind of set in their ways. They don't want to move because they're not going to be able to recapture the benefits of moving as quickly. And so typically younger doctors are the ones that are more likely to respond. The study also found that specialists are more likely to move than generalists, particularly because the specialists are the ones whose incomes are declining. It has also been found that other types of physicians seemed to be unaffected by the location decisions when there was an MCO growth in their market. So physicians who generally headed towards markets with the same or lower MCO penetration and fewer were moving to where there was more MCOs. So when physicians did move, they moved to areas where there were fewer MCOs, or at least the same amount of MCOs. They tended not to move towards cities where there were more MCOs, which kind of makes sense, right? If MCOs are the cause of these changes that are causing them to move, then it's very likely that they're going to move to a place where there's fewer of these types of insurance groups. There was one other finding from the same set of authors, and that was that large markets with large MCO penetration caused many physicians to retire early, with the results varying by specialty. And older physicians were more likely to retire, and among that group, both generalists and medical or surgical specialists opted for earlier retirement. So some pretty interesting impacts of managed care on these decisions regarding physician income, location, and mobility, as well as retirement. Okay, there's one last issue we got to cover. We're going to go through real quick. We only have 5 minutes. But it has to do with the fact that we're going back to the issue of bad risks chasing good risks, right? The issue that traditional insurance plans face with self-selection, right? And of course, in those instances, the solution was to restrict the benefits of the healthy plan in a way that the sick people didn't want to choose it. But of course, that came at the cost of the healthier people, right? They had to bear the cost of creating the separating equilibrium, right? Now, it turns out that the types of restrictions that MCOs kind of bank on might actually be able to achieve the same outcome of a separating equilibrium, where sick people choose the plan that's intended for them, and healthy people get to choose the plan that's intended for them, right? So it seems like this actually might already be built in to managed care plans, right? Can the restrictions that MCOs place on patients achieve the same thing? And it turns out, yes, right? That there are all kinds of restrictions in an MCO that a sick person would find potentially undesirable that a healthy person wouldn't find as obnoxious. And so it could be that this ends up creating the separating equilibrium that's desired, right? So the evidence on this comes from Glied, and they found that what did they find? They found that that managed care plans in private sectors tend to enjoy a 20 to 30% utilization advantage over conventional indemnity plans, while Medicare plans enjoy similar advantage over traditional Medicare. And so what does that really mean? It's suggesting that the primary outcome of MCOs may be able to create this separating equilibrium, right? Where insurance carriers can identify relatively healthy people and attract them into an insurance plan that sick people don't want to buy, right? So it turns out that this may be a real possibility. There may be a way for MCOs to achieve the sort of market segmentation that we discussed in Chapter 10, and they can do this by using basically a type of co-payment system, right, where there's a fixed fee for a doctor visit or something like that, right? So the co-payment acts as the selection device. There's one other issue related to this market segmentation idea, and that has to do with the ACA. And so the ACA actually created another type of MCO that is going to be more and more important over time, and it's called an ACO, which stands for Accountable Care Organization. Now they resemble traditional HMOs. They have a primary care group, right? A group of physicians that offer care, and they provide that care with collaborating physicians and hospitals, and they use a capitation payment system. So very similar to HMOs. And then the main mechanism here is that, or the main difference is that if care is provided for less than the predetermined amount, the ACO can share the savings under this newly created Medicare Shared Savings Program. And this is perhaps the most novel feature of the ACO program, which is a focus on quality of care. So that's really what the accountability is. It's accountability in terms of quality. So this is something that's relatively new. It'd be interesting to see what the latest edition of this book has to say about this. But this is something that is regarding Medicare and Medicaid. And the Center for Medicare and Medicaid Services has defined a significant number of quality indicators used to sort of analyze or evaluate these ACOs' performance. And in order to share in the cost savings, the ACO has to meet those standards of quality. And so really what's at heart here is that the ACO cannot simply reduce cost by reducing quality, because they face these quality standards and are evaluated on these quality standards. They have to find ways to reduce costs that don't reduce quality, and in fact may even have to try to increase quality while reducing costs in order to share in the potential savings. So that's something that we have to look forward to, is the types of results that they provide. So all right, we're out of time. So you can look at the summary here if you like on your own. You have the slides available to you on Canvas, but I'll go ahead and leave you with this. Do y'all have any questions before we go? Okay. All right. Well, thanks for hanging in there with me on that shotgun blast of information. Next week we will look at Medicare and Medicaid, and that'll be it for our semester. So Blythe is having a great time. Well, you guys enjoy the rest of your week and your weekend, and I'll see you on Monday. Bye. Oh, wait. Homework. I posted your homework just to take a look at it. Bye.